We're doing some hearing, that's why.
Yeah, it's good.
So let's start now. So in esophageal atresia, what happens? Congenital anomaly with blind ending of esophagus, which may be associated with fistula between abnormal esophagus and the trachea. What we know, we will not repeat it. What we don't know, only we will concentrate. Okay, suspect antenatally if scan shows polyhydramnias, absent stomach bubble. In the antenatal scan, along with polyhydramnias, you can also have absent stomach bubble. Okay. Then refer to fetal medicine. Why there will be absent stomach bubble here? Any idea?
If there is communication between this one distal esophagus and the trachea, there is a bubble. If there is no communication, there is no bubble.
Okay, now this is like this, right? This is what normally we see. So if suppose if this is there, there will be bubble, right? Or no?
Stomach. You did not make the stomach.
Make the stomach also the pillow.
Okay.
Yeah. Here is bubble is there.
In this case, there is bubble.
Yeah.
Okay. If there is no connection, just esophageal atresia, then there won't be bubble.
If there is no communication with trachea, no air.
But the child will not have he will not be breathing. His lungs will be filled with fluids, right? So we don't know. Just check this. What he's telling. Is it antenatally or postnatally? Okay. We have to check this because in the womb till the birth there won't be any air in the trachea. Okay, so anyways, when you show polyhydramnias, you suspect this tracheo-oesophageal, you will refer to fetal medicine specialist, and also you will plan for appropriate place of delivery if antenatally suspected. Parents should meet pediatric surgeon antenatally. Okay,
this is all you are talking about antenatally now.
Yes, antenatally, if you see that polyhydramnias and you are suspecting this, with this absent stomach bubble, you will refer to the specialist pediatric surgeon and an appropriate place of delivery. Most cases present shortly after birth. Suspect if. When do you suspect? So this is what we have to ask in history. History of polyhydramnias, plus or minus absent stomach bubble, them frothing in the mouth, drooling, respiratory symptoms on feeding. Okay. And then difficulty in passing nasogastric tube, and also anorectal malformation. Anorectal malformation, like our case we saw today. Okay. So what history? Polyhydramnias and drooling of saliva, respiratory symptoms on feeding.
Nasogastric tube also was in your X-ray, coiling of nasogastric tube.
Like that. So what is in the delivery? What do you see? If diagnosis is suspected antenatally, avoid any positive pressure ventilation, including mask ventilation, CPAP, endotracheal tube. What is
high flow nasal cannula?
Okay, nasal cannula, high flow. Okay.
High flow, but this is high flow, not the normal nasal.
Okay, mask ventilation, high flow nasal cannula, CPAP, and endotracheal tube. So if we are suspecting antenatally, we should not give all these things.
Any positive pressure should not be given.
Yeah, any positive pressure should not be given. Maybe because why it will go through this connection and make the stomach big. Maybe because this is the reason.
No, because you are giving the positive pressure to the lungs, no? You will give to the lungs. You will
from the lungs.
No, for stomach. You are right, Dr. You are right.
Yeah, you got my point.
Yeah, it will push the diaphragm more up, and it also exaggerates the respiratory compromise.
What happens in diaphragmatic hernia? We say this for diaphragmatic hernia also, right? Because the stomach will be overfilled with gas.
Yes.
Yeah. So no positive pressure ventilation, mask ventilation, CPAP, and endotracheal tube. They can ask this question. So just be.
This is
remember this.
important. Yeah.
Yeah.
Remember.
Pouch distension may lead to respiratory compromise and or aspiration via distal pouch fistula. Yeah, the same thing as we said. Pouch here is stomach. The stomach distension can lead to respiratory compromise and also aspiration, and you can have regurgitation.
Because you have connection with the trachea here.
Yeah,
with that,
Let
this,
me
so
do this diagram.
airway.
You can-
Airway connection.
Yeah, this one and this one. So here
This is what I was saying, na? Because if you give positive pressure, you have connection of the stomach with the airway. So it will be
from
like
here it will become gastric dilatation.
yes,
Become-
yes, will dilate the stomach.
Yeah. Next, if intubation indicated, ETT tip as close as carina as possible to minimize gas flow through fistula. So if this is the division, if you are planning for ET tube, here is the fistula, right? You should see to it that the ET tube is close to this carina, so that the air will not enter into the fistula. This is what he is telling. Okay.
Okay.
ETT tip as close as carina as possible to minimize the gas flow through fistula. Ventilatory pressures should be as low as possible. If any significant respiratory compromise, instigate critical transfer to surgical unit. Okay, respiratory compromise, you will also tell that you need to transfer as soon as possible so that the surgery can be done and all these problems will be solved. Okay, next we will go for confirmation of diagnosis. So for confirmation of diagnosis, what do? Experienced operator will place radio opaque 8 French NGT. So an NGT radio opaque will be placed by an experienced person. Typically, resistance is felt at 10 to 12 centimeters from nostril in term baby. So as the NG tube passes 10 to 12 centimeters, you feel resistance. You cannot go further. This is in term baby. Do not use force, may lead to esophageal perforation. AP X-ray of the whole chest and abdomen. Our picture today, this was same, like somebody has passed an radio opaque nasal tube and it had coiled up to 10 centimeters, and AP X-ray of the whole chest and abdomen. Diagnosis is confirmed if NGT is curled in upper esophagus. This is the diagnosis. Yes, passing the NG tube 8 French, and if you see curling on the X-ray. Gastric air bubble and bowel gas confirms the presence of fistula. Okay, if there is no gastric air bubble, there is no fistula. If it is there, it confirms the presence of fistula between trachea and distal esophagus. Do not attempt contrast esophagogram. No, you should not give any contrast. Only thing you have to do for diagnosis is just pass 8 French NGT. Then you can see on the AP X-ray the coiling. That's it. And it should be a radio opaque so that it's clear for you. This is very important point, radio opaque. Okay. Next is management in the neonatal ICU. This is important for us. What do you do in neonatal unit? If respiratory support required or abdominal distension, contact surgical unit and transfer team immediately. Time critical transfer. So I think under the critical care in the ambulance or how they transfer, I don't know. But you should transfer as soon as possible if there is respiratory support and required an abdominal distension. So how do you nurse? This is very important. 30-degree head up with head turned to the side to facilitate drainage of secretions. There is drooling now. Even the saliva he cannot drink. It means he cannot swallow. So you will keep him 30-degree
head up.
So we can like this, this 30-degree, like this 30-degree head up, and the face will be turned to one side so that the secretions will come down here. Okay, 30-degree head up with head turned to the side to facilitate. See, we may think this is very small, but they don't want what surgery they do inside the operation theater. They want this answer from us. What is the emergency?
They don't want you to do the surgical, they want you what you will do in emergency when you face this child.
Yes, this is what I want to tell you. Only TOF can come. It was, I think, only TOF case came there. So they will ask all these questions. 6 minutes discussion is there, no? So you will nurse 30-degree, head up with head turned towards to facilitate drainage of secretions. Pass 10 French, this one, the true tube, 10 French replogal tube into the esophageal pouch. So insertion and management is given there. If replogal tube unavailable, place 10 French NGT in pouch, aspirating every 15 minutes. An NGT cannot be placed on suction, so needs regular and intermittent aspiration. So this
is usually when surgeons will give you the plan for baby initially do intermittent suction. So this is like that only.
But I think here this tube will help you continuous suction.
Secretion suction. You will suction secretion.
But if you are doing NGT every 15 minutes, you have to aspirate. There are two options for you. This tube is the best. But if this tube is not available, you will go for 10 French
NGT.
And when you put NGT, you will be aspirating every 15 minutes.
15 minutes.
That's it.
I think these are the information they want from us.
This is what they want. If replogal tube unavailable, place 10 French NGT into pouch and aspirating every 15 minutes. An NGT cannot be placed on suction, so needs regular intermittent aspiration. So insert until resistance is met, then withdraw 1 centimeter. Yeah, this is also very important. How do you insert? Till once resistance, you will withdraw 1 centimeter back. Suppose till 12 centimeters you got resistance, you will keep the tube at 11 centimeters.
11 centimeter.
Tape securely to face, usually 10 to 12 centimeters at nostril in term baby. Place mittens on the baby to prevent tube pulling out. Okay, term babies can pull out the tube. Attach tapered end of the tube to continuous suction. This continuous suction means this tube, replogal tube.
Replogal tube.
So tapered end you will attach to continuous suction. Start pressure, this is suction pressure. I'll just read. If you want, you can remember, otherwise it's okay. Start pressure at 5 kilopascals, aiming for continuous flow of secretions from upper phagus, maximum 10 kilopascals. So continuous pressure will be given at the rate of 5 kilopascals through this tube. Then do not share suction with other drains, like chest drain, because of maybe risk of infection. Okay. Baby should be relaxed and pink with no respiratory distress or secretions in the mouth. This is your aim. Relaxed pink with no respiratory distress and secretions. Keep nil by mouth. Flush replogal tube with sodium chloride 0.9%, 0.5 ml via side arm every 15 minutes. Okay. If you are placing NGT every 15 minutes, you will do suction. If replogal continuous suction every 15 minutes, you will wash it. You have to wash it. Okay. How do you wash? You will use sodium chloride 0.5 centimeter. More frequently.
Normal saline. Normal saline.
Yeah, more frequently if visible oral secretions. If using an enteral tube to drain saliva, aspirate every 15 minutes. Same. If you are using some other tube, you will aspirate every 15 minutes. More frequently if visible oral secretions or respiratory difficulty. So the suction normally every 15 minutes, but more secretions and you have respiratory distress more frequently. If no movement of secretions in replogal tube after flushing with sodium chloride via side arm, change tube. That means it's blocked. Okay. Do not leave syringe attached to the side arm, as this will prevent tube working effectively. Change tube every 10 days or daily if viscous secretions. I don't think till 10 days they will keep without observation.
Till 10 days, so do not leave syringe affected to side arm. This will prevent to tube.
Yeah, means if you see the tube, then you will understand this. See here, what is the insertion and management? So this part you will connect to the suction here, this part of the tube. This part is the side arm which you will use for flushing. Okay. Flush tube to prevent blocking the lumen. Instill 0.9.
So they wrote it here. When you connect, keep it dismiss suction, then how you will flush.
Yeah. So pass replogal tube ideally nasally into the upper pouch until resistance felt. Then withdraw slightly and fix with the elastoplast. Okay.
Mhm.
So what are the blood samples we will collect? This is one thing. So the emergency management. after-
Flashing you are doing not to get the block, not to get the lumen block.
Yes. Mainly is you will keep the baby in 30, nurse the baby in 30-degree position.
30-degree.
Side, keep the side mouth till there is secretion, and you will not give strong positive pressure ventilations. Okay. And you will pause this tube and continuous suction 5 kilopascals. If not there, any NGT you pass, you will do every 10 minutes suction.
15 minutes. Every 15
minutes. And if there is too much secretions, you can do early. This is the basic. Samples. You will obtain an IV access. Take blood for FBC and clotting, UE, blood glucose, and blood culture. Usually, this is for the small baby.
This is routine we do.
Yeah.
The full blood count, urea electrolyte, blood glucose, and blood culture. Usually we do for
clotting
newborn.
is because he will go for operation. That's why.
Okay, yeah, clotting, coagulation profile, clotting.
Coagulation. Now, FBC we do blood glucose, blood culture because to rule out any sepsis. Glucose normally because not feeding. UE also kidney function test. Clotting is for surgery. So children do not require baby cross-match sample before transfer. So you can transfer without cross-matching. Send one blood spot on neonatal screening card to surgical unit with a baby for sickle cell screening. So that screening also you will do one blood spot and will be sent to the surgical unit. This is not much important. Then fluids and medications, what you will do? Commence maintenance fluids, IV fluid therapy guideline, give vitamin K IM, start broad spectrum antibiotic. So important here with IV fluids, because the baby is not feeding, you will also give vitamin K, which is normal, and broad spectrum antibiotics.
Antibiotics.
Then referral, examine the baby for other, this is very important to say, other associated anomalies. So examine for cardiac. When the physical examination part comes, you have to tell this. I want to examine this baby for cardiac murmur and anorectal abnormalities, limb abnormalities, everything. If major congenital abnormality is detected, discuss with consultant before arranging transfer for management of esophageal atresia, as this may not be appropriate. Suppose simultaneously the child has cardiac problem also, you have to deal with it, right? So you will discuss with the consultant before arranging to transfer. Discuss baby's condition and treatment plan with parents and ensure they have seen the baby before transfer. So this counseling the parents, discussing with the parents is very important always. You will discuss that this baby has tracheo-oesophageal fistula, your treatment plan needs urgent surgery, and before transfer they have seen the baby, and take photographs for parents, whatever. Contact surgical center to arrange transfer as soon as possible. Obtain samples of mother's blood for cross match also. Sample tube must be clearly handwritten and labeled with mother's name, date of birth, NHS number, and date and time of collection. Complete form. Add baby's details to ensure it is clear. Sample rates relates to mother of the baby being transferred. This information is required by the surgical unit. This is just information, clear labeling. That's it. You should label clearly the sample.
Labeling of the samples, huh?
I think mother's blood group for cross match also is taken because there can be, because this is first day old baby and there can be mixing of the blood, right? During like feto-maternal hemorrhage, or there are chances of mixing. So that's why if you give any transfusions, maybe they can have cross reactions.
Cross reactions, okay.
Right, Dr. Yasser, or what?
Where is he?
I don't know, he's listening or not. Okay, let's continue. Then what do? Add baby's details to ensure this is finished. Complete nursing and medical documentation for transfer and send copies of x-rays by fax. So you will send them everything. Ensure to have mother's contact details. Okay, everything. Surgeon will obtain verbal telephone consent if operation is required, and an individual with parental responsibility is not able to attend surgical unit at appropriate time. Maybe I think the mother, they are just transferring the baby. Okay.
Yeah, they will transfer the baby. Otherwise, what?
So the parents will remain here only in the hospital.
Yeah, that's why they need a telephonic consent or
Yeah,
verbal consent, because
public-
the baby will be transferred, not the mother. If mother needs to stay in the hospital, she will stay in the same place, no? Until she gets recovered, like until she is recovered.
Okay, what he is telling is verbal consent will be taken when, if an individual with parental responsibility is not able to attend the surgical unit at that
Yeah,
time.
that's what. Because if mother, she is sick,
No one
yet
is
she is
there?
not. If
Okay.
no one is there, they will take verbal telephonic consent.
Yeah, inform surgical unit staff when baby is ready to transfer, have available name, gestational age, weight, ventilatory and oxygen requirements if applicable, and mother's name and ward if admitted. So all details you have to give them clearly. That's it. So aim. What is the aim? To prevent aspiration of secretions by continuous drainage of upper esophagus pouch. This is very important for you, continuous drainage. So equipment you use is this replogal tube, size 10 French, plus one spare. Then low flow suction, that is 5 kilopascals. Regular suction should be going on, 2 ml IV syringe. Then sodium chloride to flush, and dressing and elastopattern lubricant. So what is the monitoring? Check replogal tube several times an hour and flush to prevent blocking of the lumen. So as standard is every 15 minutes, but still if you have doubt, you can flush earlier.
How
So,
many times they are telling this? See, this much, this, I think they told this so far 5-6 times. So
yeah.
this is important.
Yes, tube
Suction.
and flush to prevent blocking of the lumen by instilling sodium chloride 0.5%, 0.9%, 0.5 ml into blue side arm. If you see here,
Just normal saline.
Yeah.
If you, we will remember that way.
The blue side, we will flush from here 0.5 ml normal saline. Okay. Every 15 minutes, this they have to do.
Just not to prevent it from blocking.
Yeah,
the
another
lumen.
thing is remove syringe immediately and observing the flow of secretions along the tube. You should not leave the syringe attached to it. You have to remove it. Monitor oxygen saturation, respiratory status, and heart rate continuously. For long-term replogal use, monitor electrolytes and consider replacement therapy. Okay. So you are using your too many secretions are coming out. Always there can be electrolyte derangement, right? So electrolyte and replacement is important. Next is blocked tube. Suspect if no continuous flow of secretions along tube, means if there is no flow and the secretions are accumulating, you have to suspect blocked tube and visible oral secretions, baby in distress, deteriorating baby, visible oral secretions, clear airway with high flow oropharyngeal section, increase flow suction, and flush replogal tube with air, observing the flow of saliva along tube. So there is lots of things. When you suspect there is no flow, visible oral secretions, baby in distress. So you will use high flow suction, then you will flush with air, observe following flow of saliva along the tube. If patency is not restored, replace. Okay. Return low flow suction to previous level. If replogal tube replaced, alternate nostrils to avoid long-term stretching of nerves. So one time you put this side, another time you will put another side, like what we do in NG tube. Okay. Hello, is that clear?
Yeah. I'm hearing.
Okay. So I think at least we finished one topic today.
You have to read this guidelines every day, one.
So for facial palsy, recognition and assessment, definition. Bell's palsy means idiopathic element. Facial palsy is Bell's palsy. So you have to always exclude secondary causes of facial nerve, which can be due to infection, inflammation, trauma,
tumor,
vascular event clinically or with appropriate investigation. So before concluding that it's Bell's palsy idiopathic, you should also exclude the secondary causes, which can be due to infection, trauma, tumor, inflammation, vascular event. See, extra what we have, we normally say infection, trauma, tumor together. Extra what he has told is inflammation. And go again with the infection and some.
You just say it together, infection, inflammation, because it's both infection, inflammation, yeah. Tumor, trauma, and
vascular events. This is easy. It can be clinically or appropriate investigation. So what is the symptoms you see? So symptoms we see is the asymmetry of the face or smile and loss of nasolabial fold on the same side. So whichever is the palsy side, we will not see the nasolabial fold. And when he smiles, we will see the pulling on the normal side. And
in the healthy side, pulling will be towards the healthy side.
Yeah. Demonstrable weakness of element neuron distribution. That is loss of wrinkles on the forehead. He cannot do wrinkles on the forehead.
Just remember, upper saves upper. If it is upper motor, then it will be saved. If it is lower motor, then he will not be able to do the wrinkles.
And also there can be increased or decreased lacrimation as well. And hyperacusis is also one of the things whenever there is facial nerve hyperacusis.
Yes, hyperacusis.
There is some, I think the stapes muscle inside connected to stapes, some stapes muscle or something.
Yeah, it has connection with that, no? The facial
nerve supplies it. So it cannot control the
muscle to this in the inner stapes.
Yeah, stapes. So you can have hyperacusis and also altered taste because
it has the supply to this taste.
Yeah, anterior 2/3 of the tongue.
Anterior 2/3 of the tongue by the facial nerve.
So if this is the tongue, anterior 2/3 is supplied by the facial nerve and posterior 1/3 by the glossopharyngeal. So you can have altered taste, then you can have facial pain along the nerve and difficulty in closing eye. This we call it as Bell's phenomenon. That when he closes the eye will, you can see the rolling up of eye with open eyelid. Okay. So these are the features which we already know. So history is you have to ask any previous viral infection or abrupt onset with no progression, history of preceding seizures or head injury. So in
trauma, no? Preceding seizure or head injury. Yes.
So in the history, you'll ask infection history,
trauma,
then ask trauma history, a preceding seizure or head injury.
Any event like vascular event can have seizure. Ask about the seizure.
And even tumor can have seizure.
Tumor can also have seizure.
So
yes.
Your history will depend upon your causes. Like infection, you will ask for any recent infection, any viral infection, Lyme's disease, all infections will come here. Okay. Then for trauma, tumor, it can be seizure presentation or vomiting, headache, all these things. So head injury is trauma. So infection, tumor, trauma. And also how is the onset, duration, progression? Was it slight and it is increasing now, or it is same like that? Okay. Then examination, what you'll do, you'll do full neurological examination, including other cranial nerves.
Yes.
Very
fundoscopy also.
In these patients, always say fundoscopy, very important, you know, because it will give you the increased intracranial pressure, which can be tumors.
Tumor can have the ICP will be high, so fundoscopy important in that.
Yeah, and also in any head injury, increased
trauma,
hemorrhage or anything, right? So what we will see, what do you want to examine? This will be the question. So I want to do complete neurological examination, including all cranial nerves and fundoscopy. Okay. So next you will go for what? ENT examination to exclude cholesteatoma, mastoiditis, and always put herpes infection first. ENT examination you want to do to rule out herpes virus infection. That is Ramsay Hunt. Then any mastoiditis and cholesteatoma. Cholesteatoma is chronic otitis media.
Otitis media, chronic otitis.
Yeah. Then blood pressure to exclude hypertension. Yes. So check for lymphadenopathy, hepatosplenomegaly, pallor and bruising to exclude malignancy, because leukemia is also associated, right? So this is very beautifully here given. If we follow this, it's more than enough.
See, this is very nice here. The examination, if you neurological examination, cranial include all the whole neurological examination, including cranial nerves and fundoscopy. Very good. ENT, you will do for herpes, you will ask for the herpes, you will check the herpes infection is there. And also this chronic otitis media, cholesteatoma and mastoiditis. Very good. And blood pressure to exclude the hypertension. And lastly, lymphadenopathy, hepatosplenomegaly and bruising.
Yeah, to make ourselves easy to remember, if you go head to toe, you will do complete neurological examination, including cranial nerves and fundoscopy. This became most of the cranial nerves here only, around the head only, right?
Yes.
So then you will come for ENT examination here. Okay. When you come down, you will come for the hand for the BP, blood pressure examination. Then you will do whole body examination to check for malignancy.
Megaly, organomegaly.
Bus.
Lymphadenopathy or hepatosplenomegaly.
So let's remember as head to toe. First I will do head. That means complete neurological examination with cranial nerves and fundoscopy. Then I will come to ear for herpes, mastoiditis and chronic otitis media. Then I will come for hands for hypertension. Then whole body for malignancy. Okay. Then we will go for investigations. So always start with, I will take detailed history examination. If all history and examination is unremarkable and no other neurological signs and symptoms, so by your clinical, everything is normal except this face. Okay. If all history and examination is unremarkable, no neurological symptoms, no investigations is needed. That means you are suspecting Bell's palsy here.
Bell's palsy, yeah. Idiopathic Bell's palsy.
You have to be very careful in telling. In these words, using is very important. If there is no clear indication of any pathological cause in the history, examination is completely normal with no neurological signs and symptoms, no investigations is needed. We have to be very clear here. Okay. If difficulty in closing eye, you need ophthalmological referral. So you will say eye care. One word you can say here is, I want to eye care, good eye care with what we say lubricants and patching the eye during night. And also I will refer to ophthalmologist.
Why don't I will say I will refer to the ophthalmology?
No, but you have to tell at least basic things. Like what you will give. You can give him a simple lubricant and patching the eye. You can suggest him. Okay. And then ophthalmological referral. Bilateral facial palsy. Where do you see? In Lyme's disease, Guillain-Barré and brainstem pathology. So whenever there is bilateral, it's not usually idiopathic. It can be Lyme's or Guillain-Barré syndrome or brainstem pathology. So you will discuss with your consultant with specialist interest in neurology or tertiary pediatric neurologist. So always bilateral facial palsy, refer. Just remember like this. Bilateral facial palsy, involve consultant and refer. Consultant and specialist interest in neurology or tertiary pediatric neurologist. Recurrent facial palsy, discuss with consultant. Recurrent infections like first line immunodeficiency. Okay, he is getting recurrent infections and recurrent facial palsy also. You can go for immunodeficiency investigations, including HIV. So severe pain associated with varicella zoster. So you can have severe pain. Okay, so again, important points here is always tell, I will take detailed history, complete examination, and if the history is not suggesting of any infection,
examination is normal,
and examination is normal except this lower motor neuron finding on the face, no investigation is needed. And for eye, you will do the eye care by giving lubricants and eye patch and ophthalmological referral. For bilateral facial palsy, always consultant and referral to pediatric neurologist. And causes Lyme's disease, Guillain-Barré, and brainstem pathology. Okay. Next, recurrent facial palsy, discuss with senior. Recurrent infections, immunodeficiency. A severe pain, it can be with varicella zoster. You have to do pain management here. We all know, no, varicella zoster recurrent.
Yes, recurrent.
Yeah.
Finish?
No, not finish. Just
immediate treatment.
Yeah. Only this much is there. So in immediate.
But even though it is one page, but there's a lot of information is there.
But very nice. What you have to tell in the exam, only that much is there. Thank God.
Good.
If difficulty in closing eye, see here he is given. If difficulty in closing eye, provide eye patch and
Yes.
carbomer ointment. What is carbomer? Maybe lubricant.
Carbomer, maybe lubricant, I don't know.
Let's go back and check. Okay. If difficulty in closing eye, provide eye patch and carbomer ointment. If no other signs, no other treatment necessary. If vesicles suggest HIV, okay, HSV. So if there are vesicles in the ear and you are thinking herpes simplex virus is the cause, you will give acyclovir. Otherwise, only eye patch.
Eye patch.
Okay. Then no other signs.
This is carbomer is a liquid eye gel for just not to make your eye dry.
Oh yeah, that lubricant you can use.
Lubricant.
Within 72 hours. So if he is presenting to you within 72 hours, 72 hours means how much? 24 plus 24 is 48.
3 days. 72
days.
hours is 3 days. Yeah.
Okay, if he's presenting to us within 72 hours, then we will give 1 mg per day for 5 to 7 days. Prednisolone.
It was given in one case also, no? One scenario I read with somebody in the group. There was one exam scenario. They said when you will give it was exam question. When you will give the steroids within 48 to 72 hours you can give.
Okay, so now here he has given 72. We will just tell 72. If the child presents within 72 hours or 3 days, we will give 1 mg per kg per day for 5 to 7 days. Okay. So the treatment what you will do, even for the Bell's palsy, is eye care you will give, then you will refer to ophthalmologist, and then you will consider acyclovir only if you see the vesicles. So the only treatment you will give normally is the eye care and the prednisolone 1 mg per kg per day if the presentation is before 3 days. That's it. Okay. Consider acyclovir oral only if vesicles are there. Then next is the discharge and follow-up. When do you follow up this patient? 4 weekly GP follow-up until symptoms and signs resolved. So every 4 weeks, they should be following up with GP. 95% will improve by 1 year. Okay, until signs and
95% will
so we can just remember 1. That means every 1 month, the child should follow up with GP.
Okay, 4 weekly means 1 month. Every 1 month it should be followed by GP.
One we will remember. That means every 1 month he will follow up until symptoms and signs are resolved. And usually 95% will be out, means they will be clear by 1 year. So every 1 month follow up and the symptoms and signs will mostly 95% will resolve by 1 year. Okay. If facial palsy does not improve considerably within 4 weeks. So 4 weeks is your window. 4 weeks. If facial palsy does not improve considerably within 4 weeks, arrange cranial imaging. MRI brain with request to focus on the brain stem. Okay. So what he is telling, I think every 4 weeks you will follow up and the child is improving. Slowly he is improving. It's slowly. Okay. Yeah, but if you see no improvement, if facial palsy does not improve considerably, that means you're not seeing a considerable improvement in the child in the 4 weeks, then you will go for imaging. This question will be asked to you. When you will go for imaging in this child?
Brain imaging.
Yes.
MRI.
Yeah, when you will go. This will
4
be the
weeks.
question. Then we will tell in 4 weeks,
1
if
month.
we don't see considerable improvement in their facial palsy, then we will go for MRI brain with request to focus on brainstem, focusing on brainstem. If any other neurological signs and symptoms, consider early and immediate imaging. So without neurological signs and symptoms for Bell's palsy, in 4 weeks, if there is no improvement, you will go for MRI brain. Okay. Next is other neurological signs and symptoms. You will consider early imaging. That's it. Finished facial palsy.
Okay, good.
So we did today too. I will inform
Okay.
Rohel to read it.
To listen at least.
Yeah, he can follow and listen. So that
Okay.
when we do the video station, it will be helpful for us.
Inshallah.
Okay.
Okay, thank you.
So Dr. Yasser, hello.
Yeah, I am with you.
Okay, you got these 2 cases clear, right? You want to add anything? Tell us.
No. Everything is clear.